Hey, good afternoon, everyone. Welcome to Mount Carmel webinar series. This is a COPD month, so we're going to talk about a little bit about COPD. I know it's difficult to complete the whole topic of COPD in just a half an hour, but we'll try to do justice. We'll go with some of the basics, understanding what the disease is, and go over more details. And I'm Dr. Vadde, one of the interventional pulmonologists. So talking a few things about myself. Did my residency and fellowship at New York City, and then came to Ohio. I've been practicing pulmonologist at Ohio for the last 6 to 8 years. Always had the passion to do advanced training and procedures, so decided to go to do an interventional pulmonology fellowship at University of Illinois Chicago. And then once I'm done with that, I came back and joined Mount Carmel Pulmonary Group as an interventional pulmonologist and a critical care physician. I currently have office at Grove City and will be starting at Taylor Station as well. So we're going to talk about COPD. There is a Q&A question box that is probably you guys should be having access to. Please do not hesitate to list out the questions. I'll be able to address them as soon as I complete the presentation. So talking about COPD, we all use the word or heard the word, either someone being diagnosed with COPD or one of our family members or friends being diagnosed with COPD. So what exactly means COPD? So it's an abbreviation for chronic obstructive pulmonary disease. So chronic, it's something that hasn't been developed overnight. It's been there for months to years. Obstructive, because there is some obstruction in the lungs, airways that causes this disease. And it's a pulmonary disease, so pulmonary means lung. So it's a full form as chronic obstructive pulmonary disease. And it does have a few entities underneath it. In other words, it's not just one diagnosis. Sometimes you may hear your doctor or pulmonologist talking about chronic bronchitis. Someone does mention as emphysema. Someone mentions as COPD, asthma overlap. So it's not completely wrong to have two different diagnoses on the same patient, because you can have two different processes that do come under COPD, which I'm going to talk about a little bit in the next few slides. And COPD is not a new disease. It's not something recently discovered in the last few years or not. It's been there for centuries. In fact, in early 19th century, chronic bronchitis was one of the most common cause of death in European population. And pulmonary emphysema has been described in medical literature for the last several centuries. So it's not a new disease, but it is preventable and treatable disease. So once you get a diagnosis of COPD, we can treat it. And also there are ways how we can prevent it from occurring. But unfortunately, it's a progressive disease. What it means is as we age with time, the lung functions we normally decline with time. So when you have a disease of COPD moderate, now maybe 10 or 15 years down the line, it can get worse. So it's definitely a progressive disease. So it is caused by inflammatory changes, inflammatory response of certain chemicals or noxious stimuli to the lungs that causes this disease. In other words, you inhale something into your lungs, your lung doesn't like it, causes severe inflammation, over the months and years, leading to this problem of COPD. So symptoms wise, obviously, you probably must have noticed patients with COPD having chronic cough, having trouble breathing, and have symptoms of wheezing. And it's more than 10% of our patients who are aged more than 40 years do tend to have this COPD diagnosis. And we all know that is one of the main causes of death in the United States and is the third leading cause of death worldwide. And that's the reason why establishing a diagnosis is very important early on, so that we can start treatment early on before it gets worse and has much complications. And these symptoms are so common: cough, trouble breathing, and some of these symptoms do overlap with cardiac. It is really important to not exclude underlying heart problems together with COPD. So having a diagnosis is going to be a crucial to take care of the patients. So symptoms, you're going to have trouble breathing. Most of these patients tend to have symptoms when they exert themselves. They may not have symptoms of shortness of breath when they're at rest in the beginning, But over the years, as the COPD gets worse, they can have symptoms with even at rest. They tend to have cough, predominantly has cough with mucus, clear mucus, and they do tend to have symptoms of wheezing. And also they tend to have symptoms of hemoptysis, or coughing up a touch of blood mixed with the phlegm. And if you see the picture on the screen, so you see chronic bronchitis, you see emphysema, you see bronchial asthma. So there is always an overlap of some patients having a combination of these diseases. And the whole spectrum does come under COPD diagnosis. And having this diagnosis of COPD does also have other problems. In other words, it does increase the risk of cardiac diseases, it increases the risk of osteoporosis, makes your bones weak, can cause anemia, increases the risk of lung cancer by itself. So in excluding the risk factor of smoking, the COPD diagnosis itself is risk for lung cancer. Okay. So what is chronic bronchitis? What is emphysema? We use this diagnosis a lot. So when you see the lung, if you can kind of imagine the lungs to be more of tubes that supply air into the lungs, which you can see the main windpipe, and then you can see the branches that lead onto the right side and left side. Those are the tubes that supply air into the lungs. And then the rest of the lung is more like a sponge, wherein air absorbs the carbon dioxide and oxygen exchange occurs. So when you have a problem predominantly with the tubes, as you can see in the picture on the right side picture on the bottom, the tube, or what we call as bronchi, over the years of repeated exposure to smoking or any kind of industrial toxins, they cause a lot of mucus forming cells, leading to narrowing of the airway, causing it to call as chronic bronchitis. On the other hand, if you see the sponge part of the lung, so those are alveoli, what we call as air sacs. So they can get damaged over the time with smoking or similar noxious stimuli, leading on to these air pockets, what we call as emphysema. In other words, these air alveoli lose the elasticity wherein they normally inflate and in inspiration, and they're supposed to flatten out with expiration. But once they lose the elasticity, the patients can breathe in air, but they're not able to breathe out, leading to what happens as air trapping. So what are the causes? What causes COPD? So majority of the patients who are diagnosed with COPD do have some form of chemical that they inhale that causes damage to the lung. And smoking is one of the major factors. In fact, 80% of the patients who are diagnosed with COPD tend to have some form of smoking exposure. A lot of patients think that direct smoking is the only cause of COPD, but there is enough evidence to say that even secondhand smoking, patients who don't smoke but inhale a lot of cigarette smoke from friends or family around, do also have this risk factor of developing COPD in their lifetime. Other things that do play a role is if you are exposed to any of the motor vehicle fumes, factory power plants, or wood burning, wildfires. All these do have increased risk of to develop COPD. Farming also can cause when you do expose over the years of exposure. Biomass fuel burning may not be much of a problem in US, but the rest of the countries where they still use biomass for cooking, sometimes that can be a risk factor for COPD. And maybe it's not just smoking, it may be something genetically, some patients are prone for COPD. So some patients do have these alpha-1 antitrypsin deficiency, wherein the body does not make enough protein that protects the lungs, can develop COPD or emphysema down the line. And there are blood tests available to detect patients who have these conditions. All right, so now that we know what COPD is, what are the testing that we can use to diagnose COPD? So some of you must have been familiar with this picture or how it looks on a pulmonary function test lab. So the way we diagnose COPD is using a test called pulmonary function test. Our short form, it's called as PFT. So wherein it is an outpatient testing. You can see the left side chamber. It's an airtight chamber wherein you will be asked to sit in that something like that. and take in a deep breaths as well as breathe out completely. And then the respiratory therapist will be checking all these numbers on the monitor to see how strong your lungs are. So this is a very important test to diagnose COPD. And not only does this test helps us to diagnose COPD, but it will also give us more information. It gives us more information about the severity of the COPD, like to risk quantified, whether it is mild COPD or moderate COPD or severe or very severe COPD. And it also helps us to assess the progression of the disease. So if your patient has a COPD 2 years ago, and then you do the test today, it will tell how your lungs are, how your COPD functionality is. In other words, is your COPD getting worse? Is it getting better? Or is it the same? So it can be followed through over the lifespan of the patient. And other treatment modalities like lung volume surgery, lung volume reduction surgery, or valve placement, which I'm going to talk in the next few slides. There are some of the options that are available for patient, but will need PFT to see if they can qualify for them or they would benefit from those therapies. And also referral for pulmonary rehab would be helpful with these PFTs, and also if the patient would be a candidate for lung transplant for COPD. So all of these kind of get some information from the pulmonary function test to help with not just diagnosis, but also provide more treatment options. So talking about treatment and management, so it kind of outlines into these 5 categories how you're going to manage these patients with COPD. First and foremost is obviously prevent the disease progression. So the first thing to do is to prevent further damage. COPD, unfortunately, is irreversible damage of the lungs. So there's no going back, but we can prevent not getting worse by stop smoking or even chemicals. If their patients have COPD because of exposure to a lot of chemicals, preventing that further exposure would probably prevent the progression of the disease. And relief of symptoms. So we do have a lot of options available for inhalers wise to help with breathing, and improvement of exercise tolerance. So what it means is able to do more in terms of physical activity, such as options would be available as pulmonary rehab programs or bronchoscopy valves, and prevention of flare-ups. So it is highly recommended that patients who have COPD get vaccinated against annual influenza vaccination, pneumococcal vaccinations, as well as RSV vaccines as well. And treatment of flare-ups. So majority of mild flare-ups can be easily treated with outpatient antibiotics and steroids, but sometimes it can be severe enough that will be requiring hospital admission or even ICU admissions as well. Yeah. So prevention of the disease, I kind of probably stressed enough, but it's nothing is as important as stop smoking for COPD management. It's almost like if you do take all your inhalers, but you don't feel adequate enough in your control, is once you continue to smoke, there's an ongoing inflammation that occurs in the lungs. So whatever treatment you're taking for COPD may not be as effective when you continue smoking. Something similar like if you're diabetic and you're on insulin, and if the patient is eating candy all day, your diabetes is never going to be well controlled unless if you change the behavior of that. So it's as secondhand smoking is also a very important factor. It's not only smoking cessation helps you to prevent or reduce the burden of COPD, it does also reduce the risk of lung cancers. It does reduce the risk of heart problems. So there are multiple benefits of stopping smoking. And also it's getting expensive every day. So you're going to save a lot of money by stop smoking. Some patients asked in the office, like, is vaping considered as an alternative to stop smoking? The answer to that is we don't know yet. We don't have that longevity of studies to say that vaping is safe for the lungs. We just don't know the answer right now. Time will say if it is a safe alternative or not. And we do have multiple options for COPD. For smoking, you have nicotine patches, nicotine gums. A lot of medications are available as well. And if you're interested in smoking cessation, which I strongly advocate, I would recommend you to either speak with your primary care physician, or there are multiple Mount Carmel clinical pharmacists that are available to help you out on that. So in terms of inhalers, there, as you can see on the chart, there are a variety of inhalers. Some of them are short-acting inhalers, which work for a few hours. Some of them are long-acting inhalers, which are good for 12 hours. Some of them are good for 24 hours. Some of them are single drug inhalers. Some of them are combination inhalers, which does combine some steroid into it. Or we may have a triple therapy inhalers, wherein three medications are clubbed into one inhaler. And must have probably heard of familiar names as Trelegy or Breztri. Those are triple inhaler therapies. And these inhalers are recommended based upon your COPD staging or severity. Sometimes you may just need a single drug inhaler, or sometimes you may need a combination drug inhaler. The purpose of these inhalers is to, one, it reduces the inflammation, and the second thing, it opens up your breathing tube so that you can breathe better. And you have several other options in terms of the subclassification of inhaler. We have a MDI, it's called as a metered dose inhaler, or you have a powdered form of inhaler. Okay. So again, this is just a chart of different types of inhalers, combinations. The names are some of the brands that have its names, but you do get a generic version of most of these inhalers as well. So the difference between MDI and a dry powder inhaler, I always try to discuss this with the patients during the office visit, is the metered dose inhalers are more like a spray kind of an inhaler, wherein you spray the medication inhaler, you get a spray or mist kind of a thing, medication, where you inhale and hold the breath for 10 seconds, and then you breathe out so that the medication goes all the way in. In powdered form, you don't get the mist. You break the capsule once you activate the inhaler, and then you have to take a deep breath in for the medicine or the powdered medication to get all the way into your lungs. So there are a couple of different differences between these two type of inhalers. Generally, these are well kind of taught by the pharmacists when you pick up the inhalers, but I always reinforced going over these inhalers, the right technique during every office visit, because sometimes the medication probably would work if it's taken appropriately, because if the medication is not, inhalers are not taken properly, it's almost like a mouthwash kind of a thing, because if your medication does not reach all the way deep into your lung, it's not going to help you with your breathing. Okay. All right, the next recommendations is, if you do have your oxygen levels less than 88%, either at rest or when you walk around, then your body is saying that it needs oxygen. And when we do this testing in the office, and if you do qualify, we do all the paperwork and everything so that we can arrange for oxygen. And studies have shown that using oxygen when your oxygen level is low definitely helps survival. All right. So what are the other options beyond inhalers? So there are a couple of few other recommended treatments. One is called as Daliresp. The name of the medication is roflumilast. It does work by reducing the inflammation. It is recommended for patients who have severe or very severe COPD, who has more than 2 flare-ups per year. And also a newly approved drug that came into market a year ago, which is called as Ohtuvayre. This is something similar to Daliresp, but it's not a tablet form. It actually is a nebulizer form. It's done 2 times a day, and you can use the same nebulizer machine that you normally use for other nebulizer treatments. And it does have a very good safety profile, and studies have shown that Ohtuvayre not only helps to reduce the inflammation, but also helps to improve the lung function. All right, so the next option that we have for COPD is immunotherapy or shots. This has been well studied and has been really successful with asthma patients, which has actually reduced significant ER visits for asthma, hospital admissions for asthma. But we didn't have much data for COPD until recently, where it has been approved for patients with COPD. Not every COPD patients do qualify for these shots. Only patients who have COPD with an eosinophil phenotype, in other words, It's one of the type of white cell count that is tested on the blood test, wherein if your white eosinophil count is greater than 300, and if you do have asthma based upon the breathing study, it is kind of approved to take the shots. It's taken every 2 weeks and it's self-injected. You'll be taught how to use it at home safely. And the studies have shown that it does reduce the flare-ups by 34%, and side effect profile is very minimal. Or talking about the exercise tolerance, in other words, being able to do more activities that you're currently doing. So pulmonary rehab program are strongly advocated, and if you can take the benefit of it, I think that's the best thing that you can do, because patients that have undergo rehab programs have always have good things to say of how much they're able to breathe better, how much they're able to do more activities that they were not able to do prior. It will definitely need a breathing study to get you approved for the insurance to cover. It's an outpatient rehab programs. It's not inpatient. Typically, it runs for about 6 to 12 weeks. It's about 3 months per program, and it's about 2 to 3 times a week sessions, which generally last about 2 hour sessions. It's a mini fitness kind of a thing, wherein you'll be made to do some exercises, predominantly upper body exercises, thereby helps with breathing techniques, also endurance. And they also, in addition to making you do all these exercises, there are other uh, great options that are available together. Is you do tend to have smoking cessation counseling over there. They will be able to teach you some of the inhaler techniques, make sure you're doing the proper technique of using your inhalers, also have nutritional counseling, and it's also a group therapy. So it's a perfect combination of things that can motivate you to do better and help you with your breathing. So we do at Mount Carmel, we do have our own pulmonary rehab program. So just reach out to your primary care or lung doctor, pulmonologist to kind of see if you qualify for it. So the next thing I would like to talk about is a bronchoscopy lung volume reduction. In other words, this is one of the option that is available for patients with severe COPD or very severe COPD, wherein they, in spite of being on inhalers, maximal inhalers, underwent the pulmonary rehab program, but they still get short of breath with minimal exertion, and they're not able to enjoy the quality of life they were in the past. So these valves are placed by a bronchoscopy, as you can see in the video. It's not a surgery, it's a bronchoscopy, wherein we go with a small scope with the camera and able to place these valves inside the lungs to help you breathe. The lungs, what with the COPD emphysema, what happens is the air gets trapped in the lungs. So not only that particular part of the lung does not function, but also restricts the rest of the lungs to not function. So when we do these procedures, we go in and pretty much collapse or close the valves on that particular lobe to help to give more space for the remaining part of the lungs to expand and help you breathe. Currently in the market, there are two FDA-approved valves. One is spiration valves, and the other one is Zephyr valves. And we do have all the tools and equipment at Mount Carmel to be able to successfully and safely do these procedures. Okay. All right. This is just another step-by-step approach. And the valves are not for every COPD patients. We do screen them. In other words, they should have a lot of significant evidence of air trapping noted on the breathing study, because only when properly selected patients who have air trapping with COPD tend to benefit from these valves. So there's a lot of testing that patients undergo prior to actually having these procedures, valves placed. And also, the good thing about these valves is this is a reversible procedure. In other words, if the patient is having complications or not doing any better, or any kind of reasons, these valves can be simply removed easily with the bronchoscope as they are deployed. All right. The next thing is what can I do as a patient? How can I help my own COPD management? So the first thing, again, kind of sound like a broken record, but quit smoking is the best thing that you can do to help with your breathing or COPD. Avoiding triggers. If you are kind of having to go to any place or location, if you have a lot of these fumes, pollution, or dust, trying to avoid the triggers is also a help thing that can prevent from flare-ups, lower the risk of infection. So if being vaccinated appropriately for the flu season and the pneumococcal vaccine would reduce the risk of infections. And also staying away from friends and family when they're sick. It's hard to obviously stay away, from friends and family because we're all generally connected. But a simple a running nose or a viral flu for some patients who don't have COPD, for patients who have COPD tend to get much sicker than other patients who could have just gone away with a few days of common cold. So I would be very cautious or recommend my patients if there's a lot of flu going on, I would recommend them to stay away and yeah. So when do you call your doctor for advice? So some COPD patients do have a minor flare up. Not everything needs to go to the ER. If you do have a low grade fever, if you do have more trouble breathing than usual, and if you're coughing up phlegm, which is slightly increased in quantity, or if there's a change in color of your sputum, I would recommend to reach out to your lung doctor or primary care doctor, which for a mild COPD flare-up and can be easily treated at home with a short course of steroids, antibiotics, and nebulizer treatment if initiated early on. But if your symptoms are getting worse, or if you're coughing up blood, or if you have any signs of heart attack, or if you're having palpitations, or if you're feeling dizzy or faint or weak, then obviously the first thing that you would want to do is go to the ER and get checked out before it's too late. Yeah. On the same note, COPD has a smoking related exposure. So the lung cancer screening is another testing that has been very helpful for the patients in diagnosing. It's almost like a mammogram. It's like colonoscopy. It is highly recommended, and these are the indications for lung cancer testing. So anyone who's aged between 50 to 80 years old and have a 20 pack year smoking history, in other words, smoke for 20 years or more, do have this can enroll in this lung cancer screening program. It just takes a few seconds to get the CT scan. It's a low radiation exposure. And if everything checks out okay on the lung cancer screening, then they do it every year until the age of 80 years old. But when these scans are done, if there is any evidence of pulmonary nodule or lung nodule or anything suspicious for cancer, we can diagnose the cancer at early stage and take care of the cancer before it advances. And studies have shown that it does improve survival rate by as high as 20%. So I would strongly recommend for patients who do qualify to take advantage of this great opportunity. This You can call the number that is on the screen for lung cancer screening, or you can talk to your primary care doctor, and they will be able to enroll you in this program. Awesome. Thank you so much for having me here today for the webinar series. I'll be open for any questions or concern. All right, so I do have some questions here. Katie, can you go back to the QR code again so that they may want to access that? Awesome, thank you. All right, one of the questions that I see is, can a person with COPD end up with emphysema? So emphysema does come under the definition of COPD. So yes, you can have COPD as chronic bronchitis, or you can have COPD as emphysema. or you can have a combination of chronic bronchitis and emphysema, depending upon the clinical situation. All right, what is the number for rehab? Katie, can you go back on few slides? I think there should be a number for pulmonary rehab on one of the slides. It probably must be in the bottom. Is COPD always progressive? So, good question. So, if the patient continue to smoke, it is definitely considered as a progressive. But even if the patient stops smoking, there is a small decline of lung functions as we age. So, it is definitely worse if the patients continue to smoke, but it's much better if they can stop smoking. The disease progression also reduces. Right, how do you tell if it's just a cold or flare up? So when you do have a more shortness of breath that is progressively worsening, and if you do have a phlegm that is changing in color or quantity, that goes more in the definition as a flare up. How frequently can the pulmonary function test be done? It is recommended to have a breathing study or PFT once in every few years to see the progression for COPD patients. That's what we normally do for our patients. We get it done at least once or once in 2 years or 3 years to just to monitor their lung functions. All right. Do we have any research to support food grade flavors in vape or harmful when inhaled? We do not have any research, or at least that I'm aware of. But as I said, it may take at least 10 or 20 years before we can know any if there are any harmful aspects of vaping. We do know that the patients who had vaping related lung injury ended up on the ventilator. Of course, they were subjected to certain type of brands and flavors, but we just don't have enough evidence to say it is safe yet. So there is no, I think one of the question is there any age cutoff for more invasive treatment options for COPD beyond inhalers? There is no age cutoff for Zephyr valves. We have done patients as 80 years old or 85 years, as long as they do not have any active heart problems or conditions that limits from undergoing general anesthesia. I smoked for 20 years, quit 38 years ago. Mild COPD, should I have a CT scan? I do not know the age criteria of your Sharon, but if you're between 50 to 80 years old, I think you do quit 38 years ago. So I think right now the cutoffs have smoked within the last 15 years. You probably may not qualify for a lung cancer screening. However, if you do have any respiratory symptoms, if you speak with your primary care doctor or lung doctor, they should be able to get a CT scan if you have symptoms, but not for screening as of now. Should you use an inhaler every day if you don't have symptoms of difficulty breathing? You do not need to use inhalers if you do not have difficulty breathing. There's always a rescue inhaler that you can use as needed. Are there complications associated with Zephyr valve? Good question. So just like any procedure, any procedure, there is always a risk for procedures. Zephyr valves do have the risk and complications that can occur. One of the big thing is called as a lung collapse, which can occur from 16 to 30%. So once the patient is deemed to be a candidate, we do go over the details about the pros and cons about the procedure. And only if the patient is willing to accept the risk, then we go on to the next step of placing those valves. Oh, I think that's pretty much. At what time do you discuss goals of care for patients with COPD? And it does seem like the providers are not always comfortable. So in discussing the goals of care with the patients, obviously it's something that has to be done by a provider who knows the patient very well, who sees the patient undergoing frequent flare-ups, frequent hospitalization. So it's definitely a conversation that we normally have with the patients whom we see are getting hospitalized repeatedly. All right, that seems like we answered all the questions. Some of them are repetitious. All right. All right. Thank you so much for having me today, and have a good rest of your day. Thank you.